So the next speaker is Dr. Thierry Passeron. He's professor and chair, Department of Dermatology, University Côte d'Azur, Centre Hospital, University of Nice. And he'll be presenting us effect of Ruxolitinib cream on the achievement of VASI50 by body region and at the 52-week analysis of true 5 phase 3 studies.
Thank you very much. Don't worry, as Amit already did all the job, I will do very quickly. Indeed, we are talking about the sub-analysis of this, the 2 phase 3 study on the Ruxolitinib cream after 1 year of treatment. So here are my disclosures. So, as you know, and as Dr. Pandya just told you, Ruxolitinib cream has shown its efficacy in treating vitiligo as compared to placebo after 24 weeks in the double-blind vehicle control studies. And we all know here that, and we discussed about that, that in fact the location is critical when it comes to pigmentation. We know that the face is repigmenting quite well, and as Amit just mentioned, after 1 year of treatment, about 1/3 of the patient will achieve at least 90% of repigmentation on the face by using Ruxolitinib cream. What about the impact and the efficacy of Ruxolitinib cream on the body? On the phase 2 study, it was demonstrated that it was able to induce repigmentation in all parts of the body. And here, in these very large studies, the aim was to study exactly in different parts of the body. So I won't go into details. I may just mention you this study. So just to remind you, 6 months double-blind placebo control, then 28 weeks additional extension, all patients receiving 1.5 Ruxolitinib cream twice a day. Patients were included at the age of 12, and there was no, they couldn't be included if they are leukotrichia or already used some JAK inhibitors. And for this sub-analysis, we mostly looked at the VASI50, so 50% of repigmentation in head and neck, excluding the face, hands, upper extremities, trunk, including genitals, lower extremities, feet, and total body, excluding the face. Again, this is the patient demographics, and as was mentioned, Dr. Pandya was mentioning, it was very long lasting vitiligo, more than 10 years duration. About 3/4 were stable, 1/4 were progressive, and the majority of patients already have been treated with other type of treatments. And here are the treatment. Here, after 3 months of treatment, and you can see that after 3 months there is very few repigmentation over the body. And this is something that we have to keep in mind. We have to manage the expectation of the patient. Even with the new treatments that are right, it's not gonna repigment in a few weeks. We have to explain to the patient that we have to treat them for 6 to 24 months before having aesthetical repigmentation. However, already at 12 weeks, there was already numerical superiority of the Ruxolitinib cream on head and neck, upper extremities, and lower extremities, and on the trunk. And it, of course, at 24 months, you can see that it was much better as compared to placebo on the total body, but more specifically on head and neck, upper extremities, trunk, lower extremities. You can see that hand and feet at 6 months seems to do better, but it's not yet perfect. What is interesting to see is that after 1 year, first, after 1 year, if you're looking at the total body area except the face, you can say that for approximately half of the patients, they will reach at least 50% of repigmentation. And again, this is only in monotherapy, and I would say in real life, we're gonna combine this, especially with UV. Head and neck provide very good results, as you can see. Upper extremities, lower extremities, trunk, but also in hands and feet, you can see that there are some significant, about 1/3 of the patients who achieve at least 50% of repigmentation after 1 year of treatment. Here, and I think it's quite interesting to see, here you can see here the patient who were treated since the beginning with ruxolitinib cream, and you can see that after 1 year, it's not reaching the plateau. It's still continuing to repigment, so it's very important to explain to the patient that they would get better results after, even after 1 year. And if we are looking at different kind of body region, you can see, of course, head and neck responds much better, but the trunk is also responding quite well. And upper and lower extremities are also responding quite well. Which is remaining very difficult is for sure hand and feet. And you can see here that we're going to see after 1 year, but it seems to reach the plateau here on the hands and feet. Here are some examples. You can see that there are very nice results on the arm, but look at the wrist, which is a more difficult area to repigment. Same for the hands, and I like the presentation this morning explaining the different part of the hand. You can see that on the proximal part it was quite good, but on the fingertips there was almost no repigmentation. Nice repigmentation on the knees, and of course on the rest of the body the repigmentation was quite better. I will go very quickly on the safety because I told you it's very well related product and the patient likes to apply it. It's very nice to apply, and there is no signal when on the blood. There is no serious side effect and no hematopoietic side effect. So the conclusion here is that for sure ruxolitinib cream is effective as compared to placebo in all the parts of the body. What is also important is that it's continuing to improve, except probably on the hands and feet. So in those areas and in the rest of the body, probably we have to combine, as we discussed, to achieve optimal results for the patients. And I would like to thank you for your attention.
Thank you, Thierry, for the more explanation of using the ruxolitinib. Please, Dr. Picardo.
So that's also been given to Amit. You know, has been treated also patients with active form of vitiligo. There is any indication if associated with improvement where the cream was applied, some other lesions compared in the patients, or the improvement was associated with the general stability of the disease?
1/4 of the patients were active and 3/4 were stable. And I fully agree with Amit. I mean, especially for when we are talking about systemic JAK inhibitor, I do think that it's a good indication for all JAK inhibitors. But you have first to have the disease progression and then to repigment. So you have to take more time. And that's probably explaining why with the first data we have with the oral JAK inhibitor is a little bit disappointing, but I think this is the good indication, but we'll see. I don't know what you're thinking, Amit.
Yeah, I would just make a comment. I think systemic, the concept of systemic treatment with ruxolitinib cream is really, should not be done, because it really should be, the FDA only approved it for 10%. Some of the, we did not, it was not long enough to really be able to detect worsening the disease. However, we did notice that the areas that were not treated did not improve. So there didn't seem to be a systemic effect from it. And the FDA only approved it for 10% or less body surface area.
So in any case, were patients with the limited diffusion of the disease.
Right. But I think that if you want to stop the spreading of the disease, you have to use the systemic treatment.
And it's probably a chance having the drug being topical more than systemic because of all the debate that is surrounding ruxolitinib in systemic treatment.
I'd like to make a comment. So I think personally the cream formulation is very promising, particularly in children who initially started very limited present to us with limited skin lesions, depigmented lesions. So it's promising for them on the grounds that tacrolimus sometimes is not very well tolerated by them. And we don't really have to apply in large amount or large quantities. So I think it's promising in the long run.
I fully agree, and again, the cosmeticity is much better as compared to tacrolimus. It's not stinging, but I think that in the future we need to have different kind of treatment, because even in children sometimes it's very, very active, and for this we will need systemic treatment. But so far we are treating them with oral mini-pulse and narrowband UV.
Also, I had a question as to about the stability. So in children, how we were assessing about the vitiligo being stable or not stable during the progression of the treatment?
So far, we don't have the data, as Amit was just mentioning, after cessation of the Rix cream. I do think that it will be the same as for other treatments, although Jack can act directly on TRNs, but there are some data showing that it's not. So I think it will be the same, so roughly 40 to 50% of relapses after 1 year. But I do think also that we demonstrated some years ago that twice weekly application of topical tacrolimus is able to decrease, not to prevent completely, to decrease significantly the relapses. And I think that ruxolitinib cream could be very interesting also for that in relapsing patients.
Just one question. So the lesions which were like not treated with the steroid or any other immunosuppressant, those lesions can be treated with the ruxolitinib?
Yeah, we don't have yet, and I think it will be difficult to have a head-to-head comparison. However, as you see, about more than half of the patients were already being treated by topical treatment, UVB or tacrolimus. So, and most of them responded. So I think it was trying on those patients, but there is no so far specific study showing, okay, it's not working after tacrolimus or topical steroids, now try ruxolitinib. It could be very interesting to do that, I think.
Well, we don't have comparatives between the ruxolitinib and the topical calcineurin inhibitors, of course, but I think from the results that it lies at the same position, the same indication, I think.
It depends, because if you're looking carefully in the literature, topical steroids and tacrolimus alone, just alone, are not working that well.
Yes.
And here, it's roughly alone. On the face, there was the sun, but on the body, there was almost no sun. So I think it will be difficult to have head-to-head.
You feel it's better? I mean, of course, we will have the comparisons with statistics and numbers.
I think it's not a breakthrough, but it's clearly a progress in terms of the application and the results. Clearly.
Yes, all right. Right,
thank you very much.
Thank you. Who's the next one? And now I'm very happy to introduce the next speaker, and she is one of our junior dynamos at Cairo University at the dermatology department, Dr. Rania Mugawar. Rania is going to talk to us about a nice research about the effect of narrowband UVB on interleukin-5 and its alpha subunit receptor after treatment with narrowband in vitiligo.
Thank you, Dr. Sami, for your kind introduction. It's my pleasure and honor to be with you today. My talk is about tissue level of interleukin-15 and its alpha receptor subunit in active non-segmental vitiligo cases and the effect of total body narrowband on their tissue level. As you all know, interleukin-15 has a pleiotropic role with contribution to the vitiligo pathogenesis by increasing the cytotoxicity of the T effector cells, as well as a major role in vitiligo recurrence. Interleukin-15 is essentially derived from the keratinocytes, and in vitiligo, it's mainly transpresented through the alpha receptor subunit on the surface of the keratinocytes, where the interleukin-15 binds to the interleukin-15 alpha receptor subunit on the keratinocytes, transpresenting it to the beta and gamma subunit on the T cells. So, in the effector phase or the active phase of vitiligo, interleukin-15 has some contribution by increasing the cytotoxicity of the effector T cells and a major role in vitiligo recurrence, where it is transpresented through the alpha receptor subunit on the surface of the keratinocytes to the resident memory T cells, contributing to their survival and maturation. So as I've explained, it has a role in the active phase as well as a major role in vitiligo recurrence. Regarding the effect of total body narrowband UVB on interleukin-15 and alpha receptor subunit expression in the tissue, the literature is quite scanty. There's an old report reporting that the ultraviolet B upregulates the expression of interleukin-15 in normal skin. And another report documenting that interleukin-15 mRNA is downregulated by the ultraviolet B radiation. So in this work, we aimed at assessing the tissue level of interleukin-15 and its alpha receptor subunit in vitiligo cases in comparison to controls, as well as evaluating the role of total body narrowband UVB on their tissue levels. We included active non-segmental vitiligo cases aging more than 18 years and having a VIDA score of more than 2 or more. Any patients who took topical or systemic treatment in the previous 3 months were excluded. 60 patients were evaluated, 37 met the inclusion criteria, and 30 completed the study. Before starting the treatment, the patients were evaluated for both vitiligo extent and activity, and perilesional skin biopsies were taken from the most active lesion for assessing the tissue expression of interleukin-15 and its alpha receptor subunit. Patients were given twice weekly narrowband UVB sessions for a total of 48 sessions. After completing the 48 sessions of total body narrowband UVB, patients were re-evaluated for vitiligo extent and activity, and follow-up perilesional skin biopsies were taken next to the baseline biopsies to reassess the tissue expression of interleukin-15 and its alpha receptor subunit. Skin biopsies were taken from 30 healthy controls to assess the expression of the interleukin-15 and its alpha receptor subunit in the normal skin. 30 patients completed the study, and there was significant improvement in the vitiligo activity and extent. Regarding the change of interleukin-15 and its alpha receptor subunit expression in the tissue on narrowband, there was significant improvement in both the interleukin-15 and its alpha receptor subunit following treatment with total body narrowband UVB. So total body narrowband UVB significantly reduced interleukin-15 and its alpha receptor subunit expression. Regarding the interleukin-15 tissue expression in vitiligo cases versus controls, interleukin-15 was significantly higher in vitiligo cases in comparison to controls only prior to treatment with narrowband UVB, while after treatment there was no difference between the patients' controls. So interleukin-15 was significantly higher than controls only prior to treatment with total body narrowband UVB. Similarly, interleukin-15 alpha receptor subunit was significantly higher than controls in vitiligo cases than controls only prior to treatment with total body narrowband, while after treatment there was no difference between the patients and controls. And again, interleukin-15 receptor alpha was significantly higher than controls only prior to treatment. The interleukin-15 and its alpha receptor subunit expression were correlating with one another before treatment and after treatment, as well as the percent change after total body narrowband treatment. Different disease characteristics at the age of onset of vitiligo, the duration of vitiligo, were not of influence on the interleukin-15 and alpha receptor subunit expression in the tissues. Similarly, other disease characteristics, as the type of vitiligo and the family history, as well as the skin phototype, were not of influence. As well, the extent of vitiligo as per the VASI and the VASI score, as well as the activity as per the VIDA and the VSAS, were not of influence on the interleukin-15 and the interleukin-15 alpha receptor subunit tissue expression. So neither vitiligo extent nor activity were of influence on the tissue expression of interleukin-15 and alpha receptor subunit. So the main tissue level of interleukin-15 and the alpha receptor subunit were significantly higher in active vitiligo cases before treatment than the controls. And this highlights the role of interleukin-15 in the active effector phase of vitiligo. Following treatment with total body narrowband UVB, the mean tissue level of interleukin-15 and its alpha receptor subunit significantly dropped. And at this point, there was no difference between the difference between the patients and controls, highlighting the normalizing effect of the total body narrowband on the interleukin-15 tissue level expression. The main limitation on our study is the failure to correlate the tissue expression with the serum level, and to sum up, interleukin-15 and its alpha receptor subunit, as you all know, are potential therapeutic targets that can provide longevity And total body narrowband UVB was found to normalize the tissue level expression of interleukin-15 and alpha receptor subunit, so it can be a promising adjuvant tool for the upcoming biologic therapies when combined, as it can achieve the stabilization, repigmentation, as well as maintenance, so it can be a management pillar as Dr. Samia previously mentioned and Dr. Amir, that the phototherapy can target the small molecules as well. So again, it's a management pillar in treatment of vitiligo. And thank you. And this is a kind reminder of the VIS in Egypt. And thank you.
Thank you, Rania. Do we have any questions for her? Please, Dr. Pandya.
That was a very nice presentation. I have a question for you.
Sure.
As you know, there are studies going on right now against the IL-15 receptor as well as the IL-15 itself, because they're trying to have durable remission with removal of the resident memory T cells. So why is it after phototherapy, when vitiligo comes back, it comes back in exactly the same spot on your hand? So that's telling me that the improvement in IL-15 must be temporary. You have only shown cytokine reduction, but you have not shown removal of the resident memory T cells. Is that correct?
Sure. I totally agree. And actually what I was saying, it can be an adjuvant treatment, so it cannot definitely achieve the same effect as the targeted therapy, like targeting the interleukin-15 itself or its receptor. But again, it can be an adjuvant tool, and it has a benefit as regards the side effect profile because it has a very high safety profile. This is what I think. Sure.
Dr. Ilfat.
That was very, very well done. Congratulations. I was wondering the timeline of when you did the outcomes assessments as well as the timing of the interleukin serum and tissue measurements. Is it possible that you could have missed the shift in the interleukin-15 levels and then the improvement in the VASI or the VES? Meaning, so if you do your assessments every 3 months for a year, after you've completed the study, but the interleukin is a lagging change, then you would miss that difference between the two groups.
Sorry, I didn't know that. There was no, as per my assessment, there was no difference in the tissue regarding the activity and the stability. The outcome measures were not of influence on the tissue expression. I mean, if I follow up the patients and reassess them.
Yeah. So when? Okay, let me ask you this: when was your last tissue measurement of IL-15, and when was your last?
At the end of the 48 sessions.
48 sessions, and when was your last VASI score?
At this point.
Okay, so what if you did it at 96 weeks?
I'm not sure. Maybe you mean the same point that after stopping the narrowband, it can re-elevate, yeah?
Correct, because I'm wondering if, because IL-15 is a delayed response, so maybe the timing has to be further out. So just a suggestion is that you follow these patients, do a VASI and a VES, maybe at 96 or maybe at 64 weeks, but see if that improves and if there's a difference in the two groups.
Sure. Thank you.
Thank you, Dr. Sorry. Can I ask the last questions?
Sure.
Thank you, Dr. Mogawar, for your wonderful talk and studies. So my question is, you appear to take the biopsy from the perilesional vitiligo before and after treatments, right? So does it matter the way you take the tissue because it's going to scar the patients? And did you take it from the exact same point before and after treatment?
Actually,
That's my question.
we were selecting the most active lesion that the patient was having, and we were taking it perilegional, and this was the baseline biopsy, and the follow-up biopsy was just adjacent to the baseline biopsy. I know it's scarring, and that's why maybe having a suction blister and flow cytometry may be a better technique, but this is what we did.
Yeah, would you think a different point of tissue biopsy would differ?
No,
I mean, in terms
not
of
a
the
different
IL-15
point.
presentations, because it's adjacent to the original areas, right?
We wanted to monitor the change at the same point.
Yeah, but
So-
it's right.
Yeah.
All right,
That's
thank
why
you.
it will be just adjacent to the previous one.
All right, thank you.
Thank you.
Thank you, Dr. Rania. So the next speaker, I would like to invite Vidya Narayan. She's from the Amsterdam University Medical Center, and she's going to be presenting to us the response of narrowband UVB therapy in different body regions in non-segmental vitiligo.
Thank you for the introduction. Good afternoon, everyone. My name is, as mentioned, Vidya Narayan. I'm a resident in dermatology, and I'm doing my PhD on vitiligo at the Amsterdam University Medical Center in the Netherlands. And of course, I'm very excited, even despite the fact that we lost the football world match quarterfinals yesterday. So I'm very excited, though, to present our work here live today at the VIS. So in the coming 8 minutes, I'll be talking about the study that we carried out regarding the difference in therapeutic response to UVB phototherapy between various body regions in non-segmental vitiligo patients. So, at our outpatient clinic, we regularly treat vitiligo patients with narrowband UVB phototherapy. As you all know, it's widely used treatment nowadays for non-segmental vitiligo patients, and we often combine it with topical treatments such as calcineurin inhibitors or topical corticosteroids to enhance the treatment. And sometimes in cases of rapidly spreading vitiligo, we add OMP systemic steroids to the treatment to arrest progression of depigmentation in an oral mini-pulse scheme. And as many of you must all know, the location of the vitiligo lesions is of influence of the degree on repigmentation after therapy. However, these differences have not been fully characterized yet between the specific anatomical areas of the body. For instance, we have patients asking, will the front of my arm react the same way as the back of my arm? Which is a valid question, which we didn't know the answer to, which is why we carried out this study to evaluate the clinical response to NB-UVB phototherapy alone or in combination with topical therapy and systemic steroids in 19 different body regions as predefined by the Vitiligo Extend score, as you can see on the picture. We also aim to assess the effect of demographic features such as age, sex, disease duration, and skin type on repigmentation after therapy. So, how did we do this? We conducted an international multicenter study in a cohort of non-segmental vitiligo patients aged 16 years or older who received treatment with NB-UVB phototherapy thrice a week in combination with topical therapy or systemic steroids for a minimum of 6 months. And then photographs are taken of all vitiligo lesions before starting therapy and 6 months after therapy. And what we did is we used data of other prospective studies to include patients in our study. So eligible patients visiting the outpatient clinic were recruited in 3 different countries, in Egypt, in Singapore, and in the Netherlands. And we used the Vitiligo Extend score, which is also a validated measuring tool to assess the depigmented lesions before and after phototherapy, after which the repigmentation was calculated. So the results, we finally included 101 non-segmental vitiligo patients in our study. And on the table on the right, you can see the patient characteristics. So what you can see is that 2/3 of the patients were female. We had a mean disease duration of 6 years. a majority of the patients had an active disease, about 87%. And what we saw is that about 60% had skin types 2 to 3, and 2/3 of the patients had skin type 4 to 5. So which treatments did our patients exactly receive? 14 patients received NB-UVB alone, and 73 patients received NB-UVB in combination with topical treatment, and 14 patients mostly with active, widespreading vitiligo received NB-UVB in combination with OMP systemic steroids. And what we did is we analyzed these groups with regards to the total repigmentation, and we didn't see any differences, which is why we continued the further analysis on the total cohort of patients. So the overall treatment response before therapy, the affected body surface area was about 2.9, and it varied between patients, but we did see a decrease after treatment to overall affected body surface area of 1.5. And what was remarkable is that the female patients showed a significant better overall treatment response with a median repigmentation of 48% compared to the male patients who showed a median repigmentation response of 33%. Furthermore, we correlated the other demographic features to the overall treatment, but these, like the age, disease duration, disease activity, and the skin type, but these did not show significant correlations with the overall treatment response. And then now the most important figure of our study, you can see on the y-axis the body regions as per FES, and on the, sorry, that was the x-axis, and on the y-axis you can see the percentage of patients, and the numbers on top represent the number of patients who had actual lesions on that body area. And green represents a good response above the 75%, and orange and red are a worse response, or low response, lower than 24%. And as expected, lesions on the upper and lower face showed the best results, and lesions on the left hand, right hand, and feet showed the worst results. But we are also curious if this was statistically different from each other. So what you can see here is the same type of, actually same graph but depicted in a different way. So you can see the box plots here with the median repigmentation per body region, and we saw that the lower face had a significant better better repigmentation response with a median response of 80% compared to the upper facial region with a median response of 64%. And we did the same testing for other adjacent body regions, so the upper and lower trunk, the front and back legs, the front and back arms, but these didn't show any significant differences. So concluding, based on our findings, we concluded that the body surface area can be classified into 4 composite body regions, as you can see on the picture. So the face, the torso and limbs, the axillae, and the hands and feet, with lesions in each of these body regions displaying a similar prognosis of repigmentation after treatment. And post hoc analysis showed that these combined body regions had showed significant differences in repigmentation response. So, in conclusion, this is the first study we believe to evaluate and compare 19 different body regions after NB-UVB phototherapy. Of course, there were some limitations to our study, as it had a retrospective nature, so we couldn't monitor the compliance to therapy, and of course there was a heterogeneity between the given treatments. But this does depict the daily practice data in real life. So we believe that the body surface area can be classified into 4 composite body regions, as I just mentioned: the face, the torso and limbs, the axillae, and the hands and feet, according to the degree of repigmentation after treatment. And why is this important? Because it could be of direct use to clinicians and vitiligo patients, as it provides a more detailed information on the treatment prognosis per body region, and could also be useful for determining target lesions for future clinical trials. And of course, I would like to thank my colleagues, also Professor Esmat, who is here on the left of me, and Dr. Magawa, who just presented her work. And particularly, I would like to thank my direct supervisors, Dr. Wolkerstorfer, Professor Leite, and Professor Becken for their guidance on the study. And thank you all for your attention.